Hi, everyone, and welcome. We're going to go ahead and get started here. As people are still trickling in, we'll do a few housekeeping items real quick. Just a reminder, please mute your lines, and we will have time for questions at the end of this. You can type your questions into the chat box, or at the end, speak directly into the phone. You should have access to the mics. If you have any tabs you aren't using, go ahead and close those to save bandwidth. And then just a reminder that this webinar is being recorded, and we will upload a recording to our website, which I will send a link to after this webinar. So I'll go ahead and introduce our speaker today. It's Dr. Erin Paquette, a pediatric intensivist at Lurie Children's Hospital. Dr. Paquette is also a lawyer and ethicist interested in improving the health of children through the identification and reduction of health disparities in the clinical and research settings. She promotes practices to address social determinants of health, which include understanding the roles of medical legal partnerships in mitigating the impact of social determinants of health and on health equity. And with that, I will kick it over to Dr. Paquette.
Thanks, Lauren, and thanks everybody for joining us. I am excited to talk with you today about medical legal partnerships, kind of how they've evolved and where I think we're heading. By way of disclosure, I am part of the HRSA-funded initiative, the National Collaborative for Education to Address the Social Determinants of Health. I don't have any other financial disclosures or other conflicts of interest to report. So what we're going to talk about today is the relationship between social determinants of health and legal remedies, a bit about the history of medical legal partnerships, and the future of medical legal partnerships, including potential components of model programs. So to start between the association between social determinants of health and then legal remedies, we know from extensive research that social determinants have a significant impact on one's health outcomes. 60% of a person's health, in fact, is determined by social factors, including those related to income and health insurance, access to standard adequate housing and utilities, education and employment, legal status issues, as well as stability within the individual and family lives. We also know that despite the fact that the U.S. spends more money on health care dollars than any other industrialized country, it ranks quite poorly with respect to health outcomes that other industrialized countries fare better in. And these poor outcomes are not necessarily the result of spending too little, but really the way in which the distribution of spending occurs within the United States. So the U.S. spends less money per dollar it spends on healthcare and social services when you compare to other industrialized countries, which spend about twice as much, and many of which have better health outcomes. And so with that information, we know that sort of addressing and figuring out ways to address social determinants of health will be an important step in trying to advance overall health outcomes. In order to identify individuals who have social determinants of health, we need a way to screen for them. And screening has been recommended across a number of medical organizations, including the Institute of Medicine, the American Academy of Pediatrics, recognizing the link between poverty and poor health outcomes. And more recently, it's become a focus area for the Center for Medicaid and Medicare Services in thinking about accountable health communities and how, at a community level, we can begin to address social determinants. While we know that screening is important, there are oftentimes barriers to screening. And the largest concerns around screening are that in a healthcare setting, you may have a great tool to screen for social determinants of health, but you may identify needs that are beyond the scope of the resources that you have within your clinical setting to provide solutions to individuals, and this can make people reticent to screen. So in moving screening programs forward to identify social determinants, we have a need for care coordination and cross-sector collaboration in order to link needs that are identified by social determinants of health screening with resources that exist in the community or otherwise. And within this, we know that there is a role that lawyers can play. When screening for social determinants of health, it's been shown that each low-income individual has had identified 2 to 3 unmet legal needs. And legal needs that relate to social determinants of health can really be quite complex. They can relate to federal, state, and local laws and policies, all of which have different structures, both for identifying a legal issue as well as their remedy. They require extensive expertise in poverty and administrative law oftentimes to address. And lawyers are situated to understand these relevant policies and laws in depth, which permits them to address them both at the individual patient level, but also to think about and begin to create policy-level solutions for problems that exist not only at the individual patient level or that exist across large groups of patients or communities. In thinking about screening for social determinants of health, there are many different models for screening. This model, the iHealth model, I think is a nice, useful one, as it allows you to map a legal domain onto legal remedies and then the impact on health. And I'm going to walk you through some of that on this table. I apologize, the writing is a little bit small, but you'll get these slides as well. So to the left is the social determinant of health that is addressed in the screening module. The middle column shows how legal services play a role, and then the last column shows you the impact of legal services on advancing health. So just to walk through a few, commonly individuals may have issues related to income or access to resources in order to meet their basic needs. Legal services can help by addressing denials of public benefits related to food stamps, insurance, cash benefits, or other disability benefits. And by improving someone's access to resources, obviously they have fewer trade-offs between meeting those basic needs and addressing their health. So they're able oftentimes to be able to afford medicines and have less overall stress in their lives to be able to focus their efforts on managing their chronic illnesses. Other areas that are important for legal needs include housing and utilities. So for people who are living in homelessness, medical legal partnerships can't necessarily create housing, but they can address issues related to not being able to secure appropriate subsidies to get housing, to improve housing conditions where they're below regulations, to prevent evictions that are unwarranted, and also to address issues related to shut-off of utilities. And again, this has been shown when you reduce homelessness to reduce emergency department visits, as well as to allow people the space to be able to address their health care. From an education and employment standpoint, legal services can provide special education services for children. They can also help with employment, workplace rights issues, as well as discrimination. And particularly for kids, in terms of long-term health outcomes, we know that quality education is important. So really ensuring that schools are compliant with laws around special education can have a significant impact on later health for children. Many people have status issues, either related to criminal activity, military status, or immigration, and legal services can help with those. That positions people to be in with better access to employment and all that follows from that related to their health. And then finally, in the area of personal and family stability, legal services can help with issues around domestic violence and child custody and guardianship issues. And securing the stable family environment, again, frees up that as a basic stressor that impedes one being able to address their health care needs. So do we know anything about the impact of the efforts of medical legal partnership? And really the literature in this area is evolving on the specific impact of MLP programs across several different domains. On this table, it shows kind of key areas in which medical legal partnerships have had success, showing that individuals with chronic illness are admitted to the hospital less frequently when their legal needs are addressed. People are more likely to take their medications. They report less stress overall. They spend less money on healthcare dollars because they go to the hospital. They utilize less costly places for their healthcare. And hospitals actually also benefit can benefit by improved reimbursement related to the actions of medical legal partnerships. Some of the most compelling impacts really are seen on specific patient populations where individual health conditions are improved as a result of legal services. So in one study, just to share one example, looked back at charts of adult patients above the age of 18 with poorly controlled asthma that required maximum medical therapy. And they looked at a group that had self-reported exposures that were harmful for their asthma management, including environmental exposures like mold, cockroaches, mice, rats, or dust. These patients all received legal services to improve their domestic living conditions, ensuring that the landlords or individuals maintaining buildings were up to code and reducing their exposure to these environmental triggers for their asthma. When they looked at the analysis before and after legal intervention, they were able to show several improvements, including a significant improvement in breathing function for this population, reduced visits to the emergency department, reduced admissions to the hospital, and a decline in some of the more aggressive drugs that were necessary to treat their condition, overall lowering their disease severity classification, and ultimately showing after the intervention that legal services could have a tangible impact on their individual health outcomes. So just, one example of sort of individual effects of the work of medical legal partnerships. Scaling up impact is an important role for MLPs. In addition to individual client benefit, there are multiple examples of MLP activities that identify overarching problems that need to be addressed to impact more than individuals with single interventions. And this map kind of shows two areas in which system-level interventions were able to be achieved. So in one example, a Cincinnati MLP was able to reduce housing code violations also for a cohort of children related to asthma. What was interesting about this case is that they found a single landlord was responsible for maintaining the housing for all of these individuals that were really having untoward events related to their asthma because of substandard housing conditions. So kind of shows the benefit of being able to have a legal entity that can look at patterns over time and to identify things at a systems level in order to affect change. In Seattle, there was a similar sort of system level issue that was occurring for children that were dependent on medical technology and living in hospitals because of inability to secure home nursing in order to be able to transition out of the hospital. And the medical legal partnership in Seattle worked to change the reimbursement rates at the state level in Washington for nursing services in order to make home nursing services more available. And this allowed children to move out of the hospital and into the community because they could get the services they needed to be able to live at home. And this is important really for two reasons. One, it reduces costs at a hospital level because you are no longer keeping children in a hospital setting where they don't really need acute care, but that happens to be the only place they can get nursing. So it helps the hospital out by moving them into the community. And also from a child development and overall health standpoint, it allows these children to be placed in the least restrictive environment in order to promote their growth and development and all of the things related to being able to live in the home or in the community with their family. So two examples of impact beyond the individual patient that were facilitated by medical legal partnerships. Hopefully, I've laid the groundwork to suggest that the MLP model can be an effective tool in helping to address social determinants of health. And with that foundation, I'd like to turn a little bit to the history of medical legal partnerships, their key functions, and ongoing efforts to optimize their role in addressing social determinants. So in 1993, what is now considered the first medical legal partnership grew out of a family advocacy board at a Boston hospital. Asthma, you'll see, is a recurrent theme. The group there noticed difficulties with patients with recurrent admissions, identified environmental triggers, specifically mold, that was a core contributor, and again, landlords that were out of compliance, and this was sort of the birth of the MLP, was getting landlords to get their housing up to standard, which led to improvement in these children who had multiple problems with their asthma related to poor living conditions. This group operated for years, kind of going about doing their work under-recognized, and then in 2001, there was a New York Times article that sort of highlighted the work that they'd been doing. At the time, they had 3 lawyers. They were offering walk-in hours. Much of their work was direct client access, and they were also training doctors on how and why to access services legal services related to social determinants of health. This group began to partner with other organizations in the development of kind of the MLP model moving forward, which focused on 3 areas, and those were related to joint training, to providing direct patient or client services, and to advancing policy change in areas in which it was needed. Following from these early efforts, as the Boston model grew, national efforts emerged. So founded in 2006, the National Center for Medical Legal Partnership emerged, now in the Department of Health Policy at the School of Public Health at George Washington University. And this group really emerged to drive the field of medical legal partnerships forward. They aided in the establishment of several medical legal partnerships. The transition to Washington better facilitated policy aspects of their work, and it really acts as a central resource center for MLP activities at the national level currently. The group provides assistance in multiple areas to leverage collaborations between legal and medical services, including through education, research, and providing technical assistance in establishing medical legal partnerships. And much of what we know about the key features of MLPs comes from the work that this organization does and really in shaping the landscape and understanding of activities related to MLPs. So there are several core features of MLPs. They're created through partnerships between legal services providers, and these can be several different types of providers, which we'll review in a few minutes, and healthcare institutions. These generally have a formal agreement between the partners. These agreements outline goals, responsibilities related to the partnership, and importantly, patient privacy and confidentiality protections that are going to exist within the partnership. The medical legal partnerships oftentimes, not always, but oftentimes have a very well-defined population. This population can be defined by the disease or condition which it addresses. Many times it's geographic, and many times it's dependent on the funding source. So I will review different funding sources for MLPs shortly, but often sources come from income restricted, or funding comes from income restricted sources, and so the MLP cohort that it can serve is limited to those who fit under those income restriction guidelines. The third core element of establishing MLPs is a screening strategy. So we talked earlier about the fact that we need a way to identify legal needs through screening. So choosing a screening strategy to identify those with needs is an important element of establishing a medical legal partnership. Importantly, when developing screening strategies and figuring out how MLPs are going to receive referrals and provide services to meet the needs that are identified in that screening, it's been shown that really only 10% of individuals will need an actual lawyer to resolve their issue. This is important because we know that there are limited resources, and so there are ways in which MLPs can provide either resources for self-directed activities or other community sources that can help individuals navigate their legal needs and are able to restrain the use of their lawyers' time and actions to those cases in which an individual truly needs those services and to resolve their issue. So other core elements of MLPs, obviously you need legal staff in order to provide those services. These are usually provided by the legal partner, not supported or not employed by the healthcare entity that the partnership is made with. Many times they have what's called a lawyer in residence or physical person who's available at the healthcare setting. This in-person availability does a couple of things. It allows identification rapidly of time-sensitive matters with an individual present who can expedite making sure that if those need a lawyer, those get addressed in a timely fashion. And it also facilitates interaction with the clinical staff, which allows a better understanding of both groups in working with each other, and fostering that collaboration helps to improve the robustness of the referral process, as well as the legal services understanding the conditions within the healthcare setting to help them best address the client needs from a legal standpoint. Training is an important component of setting up MLPs. So clinical staff within healthcare institutions need to be trained to appreciate where there is a potential need for legal assistance or intervention. And training for the MLP staff on healthcare issues is also important. And then there needs to be a mechanism by which key information is going to be shared between the medical and legal partner. And this includes all of the information that we glean from screening activities where the referral is made. This is the sort of fact pattern that allows the legal services representative to move forward in addressing the needs of the patient. And then health record information needs to be relayed somehow to the legal services member. This is done and structured differently depending on the healthcare institution. Sometimes the legal representative will actually have access to the health record, like certain protected areas of the health record. Other times there may be parallel record systems that are set up in which they don't get full access to the record, but access to the necessary information that they need. And all of this is done with patient consent in order to be HIPAA compliant. MLPs have several key functions. This model kind of shows the overall philosophy of MLPs. They train, treat, transform, and prevent. So training reflects that collaboration I discussed between the medical partner and the legal partner in understanding each other's scope of work and resources that they bring to the table. It also involves collaboration oftentimes with public health and community resources, and so training across those sectors as well. Treating refers to the use of the legal expertise to address individual client needs, so resolving individual cases. Medical legal partnerships and working with several cases in an institution or a clinic often will help to transform institutional and clinical practices and policies that can respond better to patient needs. And that at a system level, prevention using evaluation of outcomes from individual client cases and pattern detection, they can identify system level problems that may require policy or regulatory agenda changes that can favorably impact population level health. So in the next several slides, I'll share some of the characteristics of medical legal partnerships across the country. This data is available on the National Center website, and it reflects a survey that they conduct both of healthcare institutions and legal services that are parts of medical legal partnerships. And this data is from their 2016 survey. So this first chart really shows kind of how medical legal partnerships have evolved over time. The lightest blue bars show partnerships that have been around the longest, longer than 5 years. The middle color shows 3 to 5 years, and the darkest color shows the most recent, less than 2 years existence of medical legal partnerships. You can see in the second bar that children's hospitals are really had led the way with having the longest standing medical legal partnerships. And the area that seems to be evolving the most right now are federally qualified health centers, which makes sense as we know that social determinants impact individuals living in poverty the most, and oftentimes this is the area, this is the location in which they receive their care. So this figure shows medical legal partnerships, the characteristics that are served by different sites in medical legal partnerships. So within children's hospitals, many of them are located 60% in underserved areas. They have a high Medicaid population, and unsurprisingly, because of ASCHIP and other programs, they have lower rates of uninsured individuals. Federally qualified healthcare centers and other general hospitals that have medical legal partnerships are located in similar areas. You can see the purple bars that reflect the FQHCs show that the majority of them are reporting that they're in underserved areas with high Medicaid populations and high rates of uninsurance or underinsured individuals. And this makes sense, as I said, because this is where populations oftentimes receive that care. This graph represents the percent of all medical legal partnerships that report serving these different populations. So children are served by the majority of MLPs. You can see the different areas in which MLPs work. From the standpoint of social determinants, housing and homelessness is a key area of importance, as is status issues and high healthcare utilizers. So these are areas where we want to see an impact in reduction of these factors, which we know if we can address will improve overall health. Some MLPs, not shown on this table, some MLPs, as I mentioned, are condition-specific rather than population-specific, although the majority of them tend to target populations or geographic areas rather than specific disease conditions. Here you can see that MLPs have several different sources of funding, of staffing for their legal services. So about 40% are staffed by Legal Services Corporation-funded organizations. Legal Services Corporation was established by Congress with a budget to provide legal services to individuals of low income who couldn't pay for services on their own. And they support about 40% of MLPs. About 30% are funded by other legal aid organizations, about a fifth by law schools, clinics within law schools, and then 10% from other sources. Of all medical legal partnerships, you can see across the gamut of social determinants, they're getting large numbers of referrals. So almost all MLPs report needing to address issues related to personal and family stability, and the majority are addressing issues related to benefits and insurance, housing, utility, education. Status issues are a little bit less often reported, and oftentimes this is because not all MLPs have the capacity to address status issues, I think not because these issues don't exist. Funding, just like legal services representation, funding for MLPs comes from a diversity of sources. There is a good amount, I think this skipped ahead, excuse me. A good amount of funding comes from independent sources like foundations or other sources. Some comes from hospitals and health systems, and then a number of different legal funding services. So IOLTA, which is the Interest on Lawyers Trust Accounts, is a kind of innovative mechanism to create some funding sources to provide legal services to low-income individuals, whereby lawyers who hold client funds in trust can utilize interest to provide those services when the interest doesn't need to go back to the client. So that's one source of money for legal services that go to MLPs. The Legal Services Corporation's funding, as I talked about, other forms of government contracts, and some legal aid fellowships. So a diverse number of sources from a legal standpoint, and then others provided either through hospital systems or private sources. While training of health staff by medical legal partnerships is a key function that the MLPs take on to teach healthcare staff about legal needs, training of medical legal partnership staff about healthcare needs and social determinants of health is also really important to successful partnership. So this graph shows the percentage of healthcare organizations that provide such training by type of organization. And you can see that overall, just over a third, or almost 40% of healthcare organizations provide such training, with the majority coming from children's hospitals. And so I think this reflects an area really of unmet need and for future development, and reflective really of the notion that looking forward, further improving the impact of MLPs will require optimizing sort of these collaborative cross-disciplinary relationships and training opportunities, because it's equally important for legal staff to appreciate the medical needs of patients and the impact of their social determinants in order to be able to better evaluate how their services are having an impact on them. Okay, so where are we going from here? A first step in determining future directions of medical legal partnerships is evaluating the outcomes of current programming. And there are several different potential areas in which evaluation of outcomes are important. As I mentioned, there are many different structures of MLPs, and thinking about which design leads to the best outcomes can be important. Thinking about returns on investment, as we know that there are limited resources, we want to know that the resources are leading to important outcomes that make a difference and ideally reduce costs and funnel it back into future work. Relationships between partners, fostering that collaboration will lead to improved success. Ways to ensure ongoing funding to support programs, looking at client satisfaction outcomes, data related to health outcomes, and then ultimately the key goal is sustainability. And there are likely other outcomes that are important to look at, or there certainly are other outcomes that are important to look at as well at a system level in terms of cost effectiveness and whatnot. When you're evaluating outcomes, you should include an assessment of potential and actual benefits, which can accrue at many levels. So evaluating things at the patient level, seeing whether there is improved overall health. At the institutional level, thinking about potential reductions in costs or improvement in invested dollars. So there's a program in Carbondale, Illinois that was able to show nearly 150% return in dollars by improving reimbursement and other insurance benefits through the use of medical legal partnership activities. And other studies have shown reduction in costs by reducing ER visits, as I mentioned, reduction in overall visits because individuals are more compliant with their medications after having their legal needs addressed, and improving lengths of stay by being able to address housing issues that may preclude discharges, and by being able to get patients out of the hospital, having an institutional benefit by not having patients that have acute hospital needs utilizing hospital beds. And then benefit at the community level. And this reflects aligning public policy priorities with the patterns of difficulties that are identified in individual patient cases that amass, or at institutional levels that need regulatory or administrative changes. And this can occur through housing code changes all the way up to sort of federal law, administrative regulatory law, or otherwise. When evaluating for benefits beyond this, we also have to identify opportunities for improvement. There are several gaps to address in moving the field of MLPs forward. Among these are really identifying the best practices to identify patient legal needs. So as I mentioned, less than 10% of needs will have will need an actual lawyer. Having good strategies to identify what constitutes a legal need to prompt that involvement. Really, I think we're still figuring out what the best way to do that is. How to evaluate the quality of MLP services. So we talked about a number of outcomes, but being able to evaluate outcomes relies on having good, validated metrics to assess what the baseline issues are and how to measure meaningful change, and whether legal services themselves led to that meaningful change. I think this is a particularly challenging area for a number of reasons. One is data sharing between medical and legal partnerships, which can be difficult to navigate for patient privacy reasons, getting access to sort of healthcare data within the hospital. But it's also challenging because these needs are complex and they're often served in a variety of ways that includes it is essential to include legal services, but may also include several other different types of services, and being able to sort of figure out what contribution each of those types of services is providing can be quite challenging. It's hard to separate out the legal services alone. And then third is to how to evaluate change that's happening at a policy or system level. So sometimes this is limited, wanting to make large changes can be limited by structures beyond the control of an individual MLP, like restrictions on when you can have a class action lawsuit around a particular issue, and legislative lobbying that's competitive with the goals of setting a policy and regulatory agenda by MLPs that address health equity and social determinants. A critical step in approaching gaps really is a continued focus on the issues that drive the need for addressing social determinants of health through medical legal partnerships. And I think at the core, this mandates continued attention to appreciating structural competency across both the healthcare and legal enterprises. Structural competency refers to this capacity to recognize and respond to the later downstream effects of the choices that we make socially, politically, and economically, and how we structure our society, and how those structures have an impact on health. It requires education of these multiple different disciplines that are poised to modify these effects. This includes, like I said, the key components to medical legal partnerships, the health institutions and the legal services, but also the other resources that help to address social determinants, including public health resources, community benefits, social workers, public policy representatives, and others. And to this end, the future of MLPs really should include multidisciplinary, collaborative training in structural competencies that occurs along the spectrum of education for individuals that are stakeholders in all of these areas in order to really set up overall community systems that can address social determinants from a number of different angles to improve health at a population level. Really identifying and bringing together all of these stakeholders that are relevant to optimizing the work of medical legal partnerships, I think it requires a bit of a paradigm shift to think about law as a primary driver of both individual and population health, and a true commitment to changing the law in a variety of ways when that's necessary in order to advance population health. To definitively address inequity and to utilize law as a key driver of social change, medical legal partnerships need to have adequate resources to scale up their efforts. And so, this relates directly to sustainability and strategy. So from a sustainability standpoint, we need sustainable sources of funding that will allow utilization of resources for individual clients, but also growing to sort of institutions, health systems, and then community level interventions. There are different types of strategies that might be effective in trying to get better resources for sustainability. So one emerging idea is incorporation of legal services under Medicaid managed care. And here the idea is that if you can incentivize screening for social determinants and getting them addressed, you might be able to better, if you can create an incentive for people to do the screening, you might be able to better get social determinants addressed that you reveal through your screening. So under this model, you're looking at screening as a quality improvement activity that's part of your medical practice that is potentially reimbursable. Then those reimbursed dollars can be put back in and directed towards MLP activities that can address issues that are identified in your screening phase. Another strategy is thinking about innovative partnerships. So we talked about the multiple functions that medical legal partnerships need to serve. And sometimes the resources that are needed to address individual client needs are best served in models where there can be rapid turnaround by individuals skilled in the law to address individual needs. And some of the other functions like education and evaluation of outcomes can be served in other models. So rather than having potentially independent medical legal partnerships that are structured, some with law schools, some with legal aid organizations, some with maybe independent lawyers, thinking about innovative models where you may bridge those groups together and leverage the resources of groups that have expertise in data evaluation, expertise in education, and then expertise in rapidly addressing individual legal needs and moving that into identifying patterns and driving policy change. If we can bring those different structures together in new types of models, it may improve efficiency and enhance how we utilize the limited resources that we have. I think in thinking about those innovative models, because there are other key stakeholders that are important in truly addressing social determinants at community level, thinking about a medical legal partnership not only limited to a healthcare institution and lawyers, but all of the types of individuals that go into making those types of groups work, like business partners that think about modeling and efficiency. If you're thinking about community resources, adding individuals with expertise in urban planning, making sure you're linked to your appropriate public policy representatives are all, I think, key aspects of the evolution of the medical legal partnership model. In thinking about this grand idea of like how do we build that ideal model medical legal partnership, of course you have to think about the resources that go into having all of the components of an ideal model present. And there's currently a demonstration project going on through Center for Medicaid and Medicare Services in this Accountable Healthy Community test that's looking at different levels of resource engagement and how it impacts key outcomes related to health that I think will provide some important data as we think about what level of resources and what level of intervention really can have the most impact. So this model test has 3 different tracks. The first track is an awareness track, and this under this track there is universal screening for social determinants of health, and then referral only to community resources. And this really asks the question of, by increasing awareness of resources, can you have an impact on reducing costs of care and utilization of healthcare resources like ED visits and admissions. The second track scales up the amount of investment and the amount of resources that are provided by adding not only referral sources, but a navigator that can address barriers to accessing resources in the community, and then looks at the outcome of whether those primary outcomes of cost, ED visits, and admissions are more impacted by the use of a navigator. And then the final, most invested, highest resource track is looking at screening, referral, use of a navigator, and then this kind of idea of community-level partnership to see if coordination with key partners and alignment in the community not only has an impact at an individual on these individual outcomes, but really at the community level in impacting community health. The project, I think, will undoubtedly create important insights into the balance of resources and results, and may lead to better understanding of best practices in how to use resources in order to best structure MLPs in line with other community and public health resources to improve population-level health and reduce the impact of social determinants on overall health. And we may learn enough to really support that model, this model MLP idea is really the direction to move in, or some other balance between resources and outcomes is sufficient. I think that in the meantime, we need to continue to think about ways to optimize existing MLP functions. So one key aspect of MLP work is ongoing training and education, as I alluded to earlier. There needs to be persistent and continued emphasis on teaching structural competency, and the role of medical legal partnerships and social determinants can only help to advance that field. To that end, one role of the MLP core of the National Collaborative is to better understand training around medical legal partnerships. And our group is currently engaged in a scoping review of existing MLP training and interviewing key informants at the National Center and MLPs of different structures in order to better inform future approaches to training education. We're looking forward to having more to share about that evaluation in the coming months, and really hope to gain a better appreciation for how to move the field forward towards optimizing this mechanism of addressing social determinants of health and improving health not only of individuals, but of the population. And with that, I think I will move on to take any questions. I'll leave you with this thought of Benjamin Franklin, and I'm happy to address any questions.
Thank you so much, Dr. Paquette. This was so great. As a reminder, you can type in your questions in the chat box, which is at the bottom right-hand side of your screen, or you can talk directly into the line. We should be unmuting these lines, so either way. And then we just dropped a link in the chat box. That's to fill out an evaluation. Please go ahead and fill that out. Your feedback is valuable. It helps us plan for future webinars. And with that, are there any questions? And reminder to unmute your lines on your end if you're trying to ask a question. Otherwise, feel free to type it in the chat box. If there aren't any questions, thank you so much for joining us. We will be around for another 15 minutes, so happy to answer any questions. If you're leaving us, thank you so much for your time, and hope you have a great rest of your day. Looks like we've got someone who wants to ask some questions typing in the chat box. You can go ahead with your question. So from Brant, the question is about Medicaid managed care. Have seen the Dallas Morning News series. It appears that Medicaid managed care denies services. Do you propose litigation to gain those services?
I think that that's a great question. Thank you for that question. I think that litigation is a mechanism by which you can try to gain those services. I think ideally you would work through structures to change the regulations and the approach prior to moving to litigation, but it was ultimately litigation in Washington State that changed the nursing reimbursement structures there in order to provide better access to nursing. So I think in limited circumstances, it's an important tool. The time frame, both for regulatory changes and for litigation, can be quite long. And oftentimes, if you can motivate change at an administrative level, it can happen a little bit faster. But I do think litigation as a last resort is an important tool to keep in mind.
Any other questions? Another question, what about partnerships with law schools on terms of educating law students and medical students together? Any such programs?
There are such programs which exist, and I think these types of programs really are ideal in building the future of individuals who have that mindset of coordinating efforts between healthcare providers and legal services representatives and other resources to address social determinants of health. I think the challenge with law school clinic models that do this type of work is that it is a training environment. It's phenomenal for that paradigm and culture shift. It can provide challenges to getting rapid turnaround of addressing legal needs for individual clients because these obviously students are in training. They require a lot of support. They rotate on and off a semester system, and so the caseloads that they can handle are smaller than that which can be handled by legal services corporations. And one of the reasons that I propose that I think combined types of models where you're both fostering the development of future the growth of future individuals who really will drive this field forward with real-time access to rapid legal services. If we can find ways to bring those groups together, I think we might be able to optimize the work that we're currently doing.
Real quick for they. Thank you.
Thank you for your questions.
It's wet.
Any other questions? I will be sending out a follow-up email with, as I said, with a link to the recording and a link to this evaluation, which you can also click on in the chat box here. And if there are any other further questions after this, please feel free to respond back to me. My email is lauren.guard@northwestern.edu, and I can get you connected with Dr. Paquette. But we'll be here for a few more minutes to take any other questions. And just a reminder, your lines are unmuted, so you can talk into the phone if you have any questions. if there aren't any other questions, I just want to say a big thank you to Dr. Paquette, and thank you all for joining us. Have a great rest of your day, and look out for that follow-up email. We'll stick around if there are any other questions, but otherwise, thank you so much.